I do that stuff. I wish you would told me that. I don't think I would be doing that. That's why I always want to pick up a pint of Ben and Jerry's in the So there's one provider in particular. Yeah. Looks like a good man. Exactly. Actually, he's doing a procedure. And that's his shoe. Because she's at a C-section.
Did you see her?
But I'm thinking about cooking some pterygoid. New Zealand.
She's not baby, so I don't know.
Actually, you're close.
That's why I talked to her after. I just don't know if she's.
I don't remember the details, but I remember some. I don't think I was super traditional salon because I helped, but she's nice enough to take a phone call. So he's not doing that. That's a big thing. That's I heard like
So I might just.
this is not for purposes in general, but you can get a license with very, very good magic. If you have a US license with firearm exams or anything, I just don't know. As long as you go within 2 years under someone, under someone, you have an unrestricted license for life. But starting in 2029, this year, I'm taking like a course including but as of right now, I just go there for 2 years and get the license. So I'm considering that. Just be like, let's just collect my licenses so I can get it. I think Denver's like,
Okay.
You could see the cases too where you can do like little lateral walls.
California.
California. Yeah, I see the guys.
Oh, yeah. Well.
No, I know. Yeah.
I might do some stuff. I could get, our summer teachers outside recovery.
It'll be a little bit better.
Yeah.
Describable. That didn't help. Okay, but yeah, maybe that would be good too. But that also means you gotta stop it and like rate it.
Yeah. There's a lot of issues. Yeah.
And our one line maybe doesn't once they give us a
Have you ever been there? You have been there? Oh, don't go to Newark. Have you ever been to Newark? Oh, the airport. Have you ever been to the city? It was like Zombieland. Oh, that's much better.
Okay, we're ready to go.
Okay, just look up my email and be there.
Yes, so if Dan emailed it over to you, so we had some internet issues upstairs, so the video is very choppy.
Right.
But we can scroll through and hit pause, so you can talk about specifics, like a screenshot.
Okay.
But it probably won't be a good display if we play the whole thing.
See what it looks like.
Yeah.
All the New Yorkers shit on it because it's not the city. So it's not the city. All the New Yorkers when they have their own all unless they're like making Can you hear me?
Chris, do you want me to hook up? Can continue for sure?
Yeah.
Yes. Yeah, go do some chat.
I'm gonna send you one. Oh, you need really good stuff.
That's really cool. Thank you.
That's fun. You're on top of it. I can tell. So keep that.
The only reason I know that is because last weekend my buddies all live in the Upper East Side, and they were all talking about the Lower East Side, and they're like, oh, it's Sunday. What's gonna be good on Sunday? It's like, the gays always party every day. Sunday's gonna be a good day with the gays.
yeah, but it's a show. They can use trash everywhere.
It's not any better.
Awesome. So we're gonna start the afternoon component of it. First and foremost, want to thank Dan and Chris for putting the event together. You guys really, came together, organized a lot of things, and I appreciate you all being here as well. And then obviously, Dr. Ohms, did I say your last name? Omes, okay. Dr. Omes for coming up here and making a long drive. So first and foremost, we were talking about the facility upstairs. Where I started off, I've been practicing general dentist for 12 years. And when I was building my startup in Erie off the 7, I was very ignorant to the way that the business world of our industry works. I made a couple of mistakes, ended up having to walk away from the project. And so at that time, my wife was pregnant with our first, and now I have 3 children. And we ended up losing almost everything. Not to the point where it was bankruptcy, but where the bank account, after stroking the checks to the architects and contractors to walk away, it didn't leave us in a great position. And so I called all the brokers. I told them, hey, find me anything. Right? My wife's pregnant. I've already kind of put in my 2 weeks notice. Find me a practice. And that's what brought me up to Greeley. So I still live in Denver and make the commute up. And so I've been behind the FAR library, just a quarter mile down the road, tucked away in small little practice that we ended up growing significantly to the point where we have Colorado Surgical Institute and the private practice all running out of this location. And so we moved into this location last year, and the philosophy of kind of what we are trying to do is, give with 2 hands and ask with 1. And so what I want to, make you guys all aware of is from the perspective of what we can do for the community. We're actually opening up this space. There's a second conference room right over there. It's a slightly smaller room to any nonprofits. And so if there's anyone in your guys' ecosystem that can do anything, we have a teachers group that comes in, we have a kindergarten group that comes in. They use the spot after hours for meetings. So I'd like to extend that to your patients and anyone within your guys' lives that potentially need a space to hold their meetings. Part 2, with some of our courses, we do teach IV sedation, wisdom teeth, single implants, lateral sinuses, block grafting, full arch, and the whole digital workflow. So from that perspective, we are looking for patients who can't otherwise afford these procedures. And so if you have any patients that might need their wisdom teeth out or might need IV sedation or implants, you can definitely send them our way. Now, we want to make sure we're respectful of the relationship, so we'll have them call not the private practice, but a separate number that kind of routes to our educational team. And then, of course, all those patients will come back your way. But it's more to just give back to the community versus us making money through the educational facility. More so than not, we're just training dentists. They'll fly in, and we train them in this setting. So we'll have a full arch group in this room. We'll have the implant group in that room. And then we go upstairs, and there's CRNAs sedating everybody, and we're all doing education surgeries. So with that said, just wanted to tell you a little bit about what we're doing. I'm here as a student with Dr. Omes. Yeah, and then maybe a patient in the chair upstairs. So we'll kind of see. But thank you guys for coming here.
Thank you.
You got a video of the tongue tie procedure. It's a little choppy, so they said. So basically, it's laser settings on this. Ulceration first. So I'm working floor of the mouth. Not overly vascular, but a little bit more than gingiva. So I picked to start with LP, and we're on that side. So that's 600 microsecond pulse, which will be less aggressive, more surfacey, create a little bit more thermal because it's spreading that energy out over a longer period of time, so it's soaking a little bit more. And then hertz of about 20. which when you get up in the LP and VLP setting, you can't go higher than 20 hertz because the pulse duration is so long, you can only fit 20 or less of those in a second. Remember that hertz is how many times it's firing in a second? So it's kind of the machine's kind of got a governor on it where it's going to take it down. So 20 hertz, it started at about 70 millijoules, which is pretty conservative. So we numb the patient, topical, put a bolus or two of anesthetic on the lateral side of the pre-numb, just kind of squeeze that in, and then once the patient felt pretty numb, I took the hemostat, basically took the hemostat and just started pinching the very part of that, squeezed down a little bit, can you feel it? Can you feel it? Can you feel it? Worked its way back, and once you pretty much told me she was numb all the way back to the extent of the hemostat, I just clamped it down to the first click, to hold it in place, cinch it up. So now what we're going to do is work on the underside of that hemostat. So that's isolating the tongue for us. It's giving us our guide to how far we're going to go. And you could use the tip handpiece. I like the tipless. Just aim the beam right at the junction of the hemostat and that tissue, and just follow it down all the way to you get to the end. So I don't know if somebody saw that. As far as when I got to the end, I just gently went a little bit further. So just following the hemostat down. Let's copy this. Yeah, I switched it to VLP just to kind of show a little bit different. So. A little high vacuum suction would have been nice. She wouldn't have get to smell it all. Anyway, I'll kind of talk through it. So once we got to the end of the hemostat, went a little bit farther, but all I saw down there was muscle fibers in the floor of the mouth, and then my nice little incision just started broadening out a little bit, and that's your indication. That's it. Don't go any further. You're just cutting muscle fibers, and you may end up hurting the release rather than helping it. So hemostat stayed in place, put a single suture, and then once I got the hemostat off of there, a lot of times what will happen is where you pinch that tissue on the underside of the tongue, it kind of almost creates a little fin, and the tipless allowed me just to kind of plasty that away so that underside is nice and smooth for the patient. So suture stays in 7 to 10 days, unless they lose it on their own. Which, I mean, if it's in there for 4 or 5 days, I'm a happy camper. But 7 to 10 days, bring them back, take the suture out, and then you could do, again, range of motion type, movements, and take a look and see. But she said, is that mom that was with her?
Yes.
Yeah, you noticed, you seemed like it
Oh,
was.
sorry, I wasn't paying attention.
You seemed like, just right away, it seemed like, you said, looked like she had more mobility than she did before.
Definitely.
Yeah, so. But oral myofunctional therapist would be great. If not, I said just move and stretch, move that tongue. Don't be afraid to move it. Get that mobility, and actually, if you had any restriction that was impeding the ability to use certain muscles of the tongue, they'll kind of learn how to do that over the course of a few weeks. So, a very, very easy procedure. The code, there is a specific code, 88 code 4. Lingual tongue tie release or lingual frenectomy. It's somewhere around 2962, 64, something like that. I used to know all those codes. Let's talk about a few other soft tissue procedures that I think just really can enhance your practice. Where's that clicker, Chris? Oh, this one, there it is. All right. So just kind of roll into this. We talk about frenectomies, freedom releases. Hey Chris, did the other thing you pulled out?
Yes. Let's see. That should be.
And then I'll advance it. Okay. So once you get acclimated to that type of working in that type of tissue, there's a lot of other things you can start to do with vestibuloplasties, which is manipulating that tissue. So it's not scary anymore when you do a few frenectomies and you kind of get to see how the results are. So there's a case where we had a cortical bone fractured probably, or a long-term extraction. Soft tissue has grown into the ridge, where if you're going to do an implant, you're not going to have adequate attached gingiva on the buccal aspect of it, or a bridge, you're not going to have a nice landing area for your pontic. So versus getting into grafting, there's a way of enlarging that ridge, and it's a matter of basically doing the same thing you do with a freedom release, is release that loose tissue, that mucosal tissue at the junction, mucogingival junction, and have it reattached down in line with the adjacent teeth, and then everything you have above that is going to grow in with attached gingiva and give you a better ridge, or give you that attached gingiva you need around an implant. So here's the case is prepped. This is kind of the diagram, what we're going to do. We're going to do our release, where the black line is here. We're going to get it to reattach in the vicinity where we have the dots, and then I did a bridge in this case. But then it gives me the opportunity to do an ovate pontic area for the pontic of the tooth. So here's the release. And it naturally pulls to where you want it to pull. So if you get it, it'll come down to where it's in line with the mucogingival junction. So before we make our temp, how do we guide this to stay where we want it? What would we do next after we did a release? Score the periosteum. Yeah, just score it again, just like we did the freedom. Score it in a line from here to here, so everything's aligned. And by the time you make your provisional, the cheek will hold this out. By the time you make the provisional, this will reattach there, and you'll get an ingrowth of attached gingiva. So we're just made a custom pontic using an ortho wire. Used our Siltec mold to make the temp. And then this is 3-4 weeks later. So now this is kind of not a three-dimensional picture, but this goes straight across, still dips in, but now I've got a lot better gingival ridge. So I've done this where I'm placing an implant. So the day I place the implant, I'll place the implant, I'll do the vestibuloplasty, let the implant heal. By the time it comes back, I'll show you a technique here quick too, that we can actually enhance the ridge using the tissue that's on top of the ridge. So, and do that when you uncover the implant, you can actually use that tissue that you normally would just, cookie cutter that tissue away, save it, you can use it. Use it as a connective tissue graft. So, final bridge, ovate site, and better tissue to put on. So, I don't know if you guys have ever seen this. Our senior citizens want to be more active, but sometimes their dental work can impede them. Of course, after that bounced in front of them. So, okay, denture, if you guys are doing removable. Yeah, exactly. That story about Alaskan fishing trip, that kind of happened too. So, right. Getting seasick with a set of dentures is not a good thing. So vestibuloplasties, this is the patient that's got kind of a very shallow vestibule, not a whole lot of room, a lot of muscle attachments that you got to work around. But when you look at these cases, you take your finger, place it up in the vestibule, and just feel for how much vertical bone that patient has, top or bottom. And you can enhance, you can uncover that vertebral bone and get it to have attached gingiva on it and deepen the vestibule so that you can use that ridge and not have a short flange with all these frenum cutouts in it. So this is, again, is just detached at the mucogingival, and as we, optogates work great, they're a natural kind of stretching and put tension on the fibers. we just release fibers. We're not cutting heavy muscle or anything like that. We're just releasing the fibers until the point of where we hit, where the ridge starts to flatten out, become a shelf. You don't go any further. So at that junction of where the ridge flattens out in a vertical, what are we doing again? Score the periosteum. Okay. Take the patient's existing denture, reline it first. Don't border mold. Let the flanges overextend. Do this, and then they wear their denture, which will help keep this up there. But also that score line will stop it from migrating down. And everything from here to here fills in with attached gingiva, and you can almost double your ridge in some of these cases to work with. There's another case. Vestibuloplasty. And after healing, so they went from about here now all the way up to here at 30 degrees around the whole arch. So here's a case where this patient, it's kind of story with her. She was a patient of mine and lost track of her, didn't see her for about 9 or 10 years, and then she called in tears. In the meantime, she had oral surgeon took out all of her teeth and fractured the cortical plate here, and basically told she couldn't afford implants, but basically told her he didn't think she'd even be able to wear a denture, didn't have enough to work with. So she came in, and we went and did upper and lower, didn't have much to work with in this area, but the posterior and around the frontier, we were able to get a lot of exposed ridge, and we were able to make upper lower dentures, non-implant retained, that were really, really retentive for her, and she was super thrilled with it.
What's your post-op care for that?
Just rinses, some kind of just have to use, like, I'd use it Stella Life now, but I use chlorine dioxide rinse, saltwater rinses, wear the indenture. I want them to have that denture in there, you know, take it out, wash it, whatever, clean it, bring it back in. I bring them back in about a week, 5 to 7 days, just look and see where, because I've overextended that, and I'm not really adjusting it until about 5 to 7 day point, because then I can see where there's truly a sore spot, and then I'll just cut out that area of the soft liner, and then they continue to wear that denture for the next week or two. And typically, it's not hard to get a patient to wear a denture like 24/7. They're doing it anyway.
How painful is it?
I mean, it varies. I mean, it's sore, usually 48 hours. Tylenol and Advil. I dropped my DEA license 15 years ago. I never prescribed narcotics. So after about 5 years using lasers, I'm like, you know, the only people hitting me up on narcotics are the druggies that are, you know, trying to get them. So I just didn't renew it. So, but yeah, Tylenol Advil combination is all I ever use in these surgeries. So here's a case with hyperplastic tissue in the anterior part of the ridge. So we have that in an extremely shallow vestibule. So what we're going to do in this case is we're going to, before we reline the denture, we're going to, before we reline the denture, we're going to remove the hyperplastic tissue. Because if I reline first and I remove that, I create a gap that can allow that to grow back in. So we're going to plasty away this tissue on top of the ridge right in here until we're down to about 2 millimeters of coverage. And then after we do that, we'll reline it, overextend the flanges. So that's a removal of the hyperplastic tissue. The best laser tip for that is that chisel tip. You know, it's just because you can use it rather than trying to airbrush that away, which would take forever. That chisel tip allows you to use it like a planing tool, and you can grab that tissue and just start planing under it, and then just get it off in a bulk amount of tissue, and then smooth things out at the end. And then we did the vestibuloplasty, same day. And this is about that 5 to 7 point. We've got a little bit of sore spot, I'll say up in here. This is just growing in. And then a couple weeks out, it's healing nicely. You can see the junction of where we scored the periosteum is starting to reattach right there. And usually within about 4 to 6 weeks, you're ready to make the new set of dentures. So another case, this is like an 85-year-old gentleman that was on some kind of a blood thinner. I don't know if it was Plavix or Coumadin or whatever at the time. So I was a little worried about bleeding, so I used a diode to do this. It took forever, but it worked. I mean, that's where he, so released, clean as a whistle, but from a time standpoint. But where you can see right there, it's scored the periosteum, and kind of follow the line around. And that's about 3 weeks. This guy healed up great. So, yeah, about 3 weeks. And a huge rib. Just one of those dentures that you have to teach him to blow up under it to get it out, because I can't even, that or go to Hobby Lobby and get a knitting tool to pull the thing out. It was unbelievable. So, other things, epilus removals you can do. Again, like chisel tip works great for those. Different types of just hyperplastic growth. I don't know what that is. It's just, I don't know where it came from. But we went in and it was kind of interfering with the denture fitting decently, so went in and removed that bunch of tissue. And that's you were asking about biopsy, something like that. It's fibrous looking tissue, but really, you know, any weird looking lesion or whatever you take out of the mouth, they really recommend get a biopsy. I mean, it'll come back. So, you know, we're charging them to remove it anyway. Their medical will pay for the pathology report. So if you live in a town that has a dental school, I mean, most dental schools, you can send it to them, to the oral pathologist. If not, Quest Diagnostics is who we used to use. And we'd fill out their medical form for them, and they would get paid directly by the medical. Roof of the mouth. This guy had just enlarged rugae. This thing was almost, I thought it might have been a papilloma. It just, he played with it. It was like on a stem almost, so we removed that. And it came back, irritation fibroma, so, but I thought it could have been a papilloma. So this is really cool. If your surgery center, man, you guys should do this. Have you heard of a lip tack or lip tuck?
No, but I'm taking notes.
Okay, so this is working up in the same tissue, but this is a cosmetic procedure as an alternative to orthodontic surgery or Botox that reduces the gumminess of somebody's smile. So this is your patient, comes in. First thing I look at on these patients is, can I do something contouring the gums to improve their white to pink ratio? Okay. So, but she's got very nice rectangular teeth that follow her face. Her features really good. So I don't want to make her teeth longer, make her look like Mr. Ed. That's probably over some of your head right now. So, I mean, she could go and get Botox every 3 months or whatever as well. Orthodontic surgery, I guess, is an option. Or what we're going to do is a procedure where we actually shallow the vestibule, and it restricts the height of the lip in a smile. So, and this is the results you can get from that procedure. So, I did this, was able to get some good cases. I did a training down in Miami about a month and a half, 2 months ago, and we did 5 of these cases. She's a very high-end cosmetic practice and wanted to learn this. So, and they had a great videographer. It was awesome. So, this is kind of a quick, shows the procedure. So we're going in and we're measuring how much restriction we want on the lip. And if you want 3 millimeters, you need to double at minimum. You need to double the width of the tissue that you take out. So we're starting at the mucogingival, and we're going up the vestibule, and in this case, we're removing about 6 millimeter wide tissue swath, all the way from about the mid first molar to mid first molar. Stay away from the parotid ducts. And we'll basically dissect that width of tissue. Now leaves a gap, right? And then we'll suture down the tissue at the height of the vestibule to the gingiva at the mucogingival junction, and let that heal. It reattaches there, and then that restricts that lip. Yes?
What's your suture choice? And
I use non-resorbable for both, and I use a heavier suture, interrupted on either side of the frenum, about midway back and all the way back is my single to hold things, and then we do a mattress suture down each side with, so I'll use about a 3.0 for, I think it was a 3.0 for the interrupted and like a 4.0 for the mattress. And then post-op is they just don't lift your lip. They need to be extremely careful, soft food. Nothing that'll tear those sutures free, but we really suture them up heavy. So this is the interrupted suture on each side of the frenum, because we want to make them, when you put them back together, you want to make darn sure you have their lip in the center of their face. So when you're done, so you can kind of see how it's.
Are you pre-marking your measurements
Yes.
with like a
Yes.
surgical pen or marker?
Yeah, we're taking surgical pen. We're measuring, we're pre-marking. You could gingival junction on one side, so that's your mark, but we go up from that and we measure and use a surgical pen, and then that's what we follow. And I always do the vestibule cut first, and then, because I know where the mucogingival cut's gonna go. So this is her case, how she started.
How long after was that picture taken?
That was taken about a month.
Okay, what's like the following days following the surgery?
It's very tight feeling. Well, it's even more restricted than this at that point, because they need to know your lip's gonna feel extremely tight for the first week or two, and then they'll get used to it. It'll just kind of build itself down. So again, discomfort post-op, 24 to 48 hours. So we did follow up the cases we did on Thursday. We talked to them on Friday, said they were sore. She called them on Saturday. By Saturday, they weren't sore at all anymore, so, yes.
Are there any contraindications for this procedure?
I mean, not really. The other thing I noticed with this procedure is, when you do that, it ends up giving them a fuller upper lip too. So, and I think you can see this in a couple of these cases. Not really that I know of, besides just medical type stuff, you know.
Okay, thanks.
So I think your only limitation is if, say ideally you want to drop the lip 3 millimeters, you want to take 6 millimeters, and in that case, they don't have enough vestibule to allow you to do that. So, but most of the time you can get that 3 millimeters. That's usually consistent, yes.
Yeah, no, this is perfect. I have patients where they have full arches.
Yeah.
And then 2 or 3 years later, they smile fully, and they start to show the prosthetic transition line, because
Yeah.
the musculature pulls up more. And so this is, I think, gonna really help out a lot of people, so thank you for covering that.
So this is the case, I take pictures, get them to do their most reproducible smile, and then just going through like PowerPoint, I'll sit there and measure out kind of treatment plan, where I want the lip to end up, and then it kind of gives me a determination of how much tissue width we're gonna get. So that's what we did with her. And I think that's the one, if you look at the on these cases, look at the upper lip fullness, because like shallow net vestibule tends to bring the lip out more.
Yeah, it's huge.
So that case, that one's noticeable. So this case, and she's pretty cool as well. So a lot of gumminess, and that's where we took her case.
You have patients sedated when you do these?
Local. So this is kind of cool. This is the doctor done it she had, like I said, videography and marketing. So, and she's Cuban. You can kind of tell with the music here. So she put together her guy does it put together a marketing.
What does one charge for that?
I'd say the ballpark would be somewhere around $3,500 to $4,000.
How long does it take?
Cosmetic.
Takes a good hour. I mean, a good hour. So.
You said mid-first molar to mid-first molar?
Yeah, so this is, I kind of go through this pretty long video, but that's kind of the mark. So this case we did over in England. But did some gingival recontouring, but that's the mark we're gonna make. Use a period finger probe or something to measure. And yeah, I like to go to about the mid of the first molar. Yeah, because it said you get beyond that, up in that vestibule, you start getting the parotid duct, and just I don't want to be anywhere near that. So just mark back and just measure based on your pictures. And then I always like to start at the frenum and just kind of do the frenectomy. You start off and you've got that diamond there, and then what that diamond helps you approximate at the end, because you just put the corners together. So with that interrupted suture, so put that together, make sure that's lined up, go about midpoint, and then, you know, 2 going back, just to really cinch things, and it makes doing a mattress suture a lot easier. So once you have the mark, you can go in and take your laser tip and actually just do a little punch in a few spots to kind of give you your height. So if the ink is washed off or something, you've got your little marks that you can follow. So I'm just doing a little punch hole right along the line. So while I'm doing one side, if the other side, the mark comes off, I've got a reference point now. So it's basically a split thickness flap that you're removing. Going through, you're not messing with periosteum. So just that thin tissue, loose fibers that are holding it in place, and just release it, and then taking this part right up here, your incision line there, suturing it down to the mucogenital junction. Like I said, it's basically you're shallowing that vestibule, and then can't raise your lipocine.
Is that tissue flap the same thickness all the way through, or do you taper it towards the end as you get to that first molar?
Taper it down to the first molar, yeah. Yeah, no, we don't,
It's
because
not
I want to
full.
close it,
Right.
so
Right.
I don't want a big box.
Yeah.
So yeah, it tapers down so you can get a nice closure on it. So frenum first, and then work our way back, all the way back to our endpoint, and then we'll go and do this end of it.
Are you going to periosteum at this superficial incision?
No.
Or no?
No, not touching the periosteum at all. No scoring the periosteum, nothing. This is,
Right.
because we're getting primary closure. We're creating
Are
primary
you
closure.
ending at this, above the periosteum?
Yeah, you're gonna
How
end
deep
above
are
the
you going?
periosteum, but you're not gonna laser affect the
Right,
periosteum.
right.
Yeah, don't touch the periosteum. So, but you're pretty much down to periosteum, you know, under that section that you're taking out.
Okay.
So it's pretty thin tissue, so the laser will, you know, incise through it pretty quickly. Again, what pulse duration would you look to use for a procedure like this? You know it's gonna bleed. Yeah, VLP's the best. The tissue's thin, so it doesn't take, you know, you don't need a lot of power to get through it. And the more you can, you know, so the more you know, you're not gonna create enough heat that's gonna keep things from healing properly. But you're gonna cut down. This is done with a Hoya Caballo laser, which had a set pulse duration of 250 microseconds, which this procedure was much bloodier, and it's because of the limitations on the machine. I mean, this pulse duration, they didn't give you the choice. So with the Fotona VLP, will definitely, gives you 4 times the pulse duration, which will help. You're still gonna get some bleeding, but it's nothing like, you know, like this case. move on, or you wanna keep watching the video? I don't know, after lunch, whether, better than before lunch? So once you get both incisions back to where you want it, then use it, take a tissue forceps and just do a sharp dissection of that segment of tissue. Here I used a chisel tip just to kind of be able to undermine it, sharp dissect it.
Do you specifically market Gummy Smile Solutions, or is it just more of a, they walk into the practice, you see it, you have this in your armamentarium?
Yeah, Dr. Martos is marketing doing this, you know, just all the time. I did it basically on, you know, when I worked up a cosmetic case. You know, it's like, you got, how do you like your smile? They said, oh, it's too gummy, and if I couldn't fix it gingivally, you know, this was an option that I could bring it down.
Have you ever seen a case or had a case where the removal was uneven for whatever reason, and then the lip moved asymmetrically?
I haven't had it, but actually, on the other hand of it, you could fix an asymmetric lip by removing more on the higher side than the lower side, and actually improve it. And I think that last, she stayed about the same. The last patient had an asymmetric lip. You know, so, and that was kind of, you know, that's the kind of concern, but if they've got an even smile, just got to make sure you mark a nice even, you know, on both sides. But like I said, hers, you know, had that, you know, said maybe cheated a millimeter or two more on one side, and then you balanced it better.
Okay, so for every millimeter.
For every millimeter of lip restriction, you need to take 2 millimeters of tissue width. So.
And you mentioned there's a limitation by the depth of investigation.
Yeah, if you got somebody comes in that just look, I mean, they're 6, 7 millimeters up above, you're not gonna get 12 or 14 millimeters. I mean, you're gonna be at the height of the vestibule completely, in most cases, before you get that amount of thickness. So you're gonna have to compromise. You know, I tell the patients that I can get you to here, I'm sure I can get you to here, but I'm not gonna get your lip down to the height of your teeth. You're still gonna show some gumminess to it. So, but you can see the piece of tissue that's coming out there. It's just being held by loose fibers. We're just breaking those away. And then the last thing we'll do is right at that triangle of the frenum, we'll do that, and then the whole thing will come out. You can take it out one side or the other, but the whole thing will come out one piece too. So, but then, like I said, what that leaves you then is you've got that nice triangle of your frenum, and it kind of gives you a reference that you can put your suture on each side, get that lined up so they're not wacky on the side, and then just, you know, the gap here, I like to just close it and get it close, and then it makes natural suturing be easier. Well, that's the very end. Just the frenum to go. Sorry. So. Yep, and there you see a little triangle, the frenum. So, and now it just gets sutured back in position. All right. Like I said, yeah, you get used to some of this tissue stuff. It's like, I can do that. They're not going to die. You know, this is do it with laser. So, biopsies and tissue removal. You guys use laser, your laser to do that? Do some biopsy work? Nope. Not yet. So yeah, any of these, whether it's a papilloma or, I mean, there's really, you've got 3 basic types of biopsies you're going to do. Is something that's excisional like this, okay, where you've got it's sticking out like a fibroma or a papilloma, and in that case you're going to trough around it, keep the margins, and then put tension on it, grab a tissue forceps, or some people talk about throwing a suture through it to be able to pull on it, to stretch the fibers, And then as you release, once you get to the other end, on the other side you troughed, it just comes out. There's incisional, which would be like, say you have a white leukoplakia on your cheek or roof of your mouth. It doesn't stick out, but you do the same thing. You're still going to trough around at 2-3 millimeters deep, be able to get the edge of it and remove it, so you have that sample to send for biopsy. And then there's, instead of something like a mucocele that basically is inside, you're removing a structure like that. So the first one here was typical excisional. When you look at this laser, you look at this lesion, look just by the coloration of the lesion and tissue, what are you thinking? Is this vascular? Yeah, definitely. So you got two lasers that you're exposure. I mean, what would you use? What would be your choice to do this? Pardon? Yeah, I'd do the ND. Yeah, I'm looking at this going, yeah, I could get this out with an erbium, but I may be here for an hour trying to, this thing is just screaming and bleeding. So I took it out with the ND gag. Just got it completely removed.
What did you use for the first one?
Erbium. So, and something like you're on your erbium, something like that, one of the little conical tip works really good because it creates a nice little trough around it. So let me go back here. So, but yeah, so we took this out with the NDA, controlled bleeding and the whole thing. And then the patient came back in about a week or two. It's all healed up nicely. So just picked it because of the vascularity. So, but this is a conical tip, works really good. So typical fibroma, go around the outside of it. Preferably, I would go about 2 millimeters beyond the extent of the lesion, so you can get some normal tissue to send in, along with the lesion. So that's probably a little bit close, but I would trough around them like that because if you're working, say, in the cheek, somebody who's got that, say, in their cheek, I made that mistake where I just started on one end, kept going. Before I knew it, I was like going beyond the lesion and like dissecting part of the cheek because I didn't have a release point. So if you trough around it like this a couple millimeters, then as you remove the fibers and you get to the other side that you can't see as well, boom, it comes right. You created your release point for it to come off with. So stretch it so you can see the fibers and just light or just out of contact, you're just ablating those fibers.
Is there an application, not like an excisional type of capacity, but for maybe like the photobiomodulation for patients with lichen planus or anything like that?
Yeah, they are doing it and showing that it improves it.
Okay.
Yeah, it doesn't make it go away forever, but particularly if they come in and they're having symptoms, then it really helps. And you're using, just one of the, usually like the medium-sized Marco tip is pretty good because it covers a decent area. So, but you can do it with a bare fiber too, but as I said, you kind of got to move it more all over the place. So, what you want to end up with the excisional, or either an incisional, is a concavity. So we do not suture these, okay? Because otherwise we'd have to extend it in an elliptical manner. And I've had a couple of these that were removed by oral surgeons, and they came back and they had a scar where the suture line was, and I had to take the laser and plastic that away, kind of like we did with that tongue tie.
So when you, at the end there? when you
That's
were doing
just a
kind of
laser
this
Band-Aid. All I'm doing,
Laser Band-Aid.
yeah, on it,
You don't have
you really wasn't bleeding much, it was just kind of oozing. If it does that, if you take, that was a small tip,
Right.
a tipless or chisel, and just turn the enter, defocus, walk in until you just start to see the dehydration of the surface tissue, and paint it in. After you get all painted, just watch it for about 5 or 10 seconds. If it's not oozing, leave it alone. Don't wipe it with gauze or anything else. That seals those little small vessels, and the patient can walk out without a bleeding lid. So it's just kind of called a laser Band-Aid. And it disinfects it too. So here's a another one, just a tongue, again, excisional. So, but that conical tip is the same type of tip as that. It's very, it tapers down to a point, so it's very precise to get around these things. And some people like to use this tip for some bony procedures. I don't, because this is a sapphire tip, and the bony procedure will chip it, and if it chips it, you can't polish these. So I use, if you've got that tip, I save it for soft tissue procedures only.
Just a quick, if you don't, so the sapphire tip versus the
Quartz.
quartz.
The quartz
If you
tips,
don't remember, how, can we tell? Like, should it say on there? Now I don't, I'm just trying to.
well,
get
what you can tell
it in
is,
my office.
it's number one, the quartz tips you probably have are amber in color. They're kind of that
Okay.
yellowy brown. If not, look in the very back side of it. If you see a glass ball, it's a quartz tip. So if the end, the hub, if you look in the back side of it and it's hollow, it's a sapphire tip. So,
You can polish sapphire tips?
no, they're hard. I mean, not really. So, you know, like your chisel tip is big enough, tough enough, it can handle a lot. But that conical one, it comes to a point, so, you know, they'll do some PDL like extraction with it, and I'm like, man, I've tried that, and inevitably, one or two times, my tip chips or gets ragged. Well, then your energy is all over the place, it's not focused anymore. So, and I'm looking I'm trying to make tips last as long as possible.
So quartz tips for.
Quartz tips, yeah, for that kind of stuff, because if they get rough on the end, you can polish them. And you polish them darn near as like brand new, they're just slightly shorter, so, which is no big deal.
What's the cost of a tip?
Good question. Dan?
Like
Yeah, they're not cheap, they're not cheap.
They're not cheap.
I'd say $150, $200, I don't know, I don't know.
more than.
More than that.
Oh, than a fiber? Or, yeah. So, this is one that, one of our students that took our class had sent, this big lesion on the lip. You just kinda got the parameters of how to do it, just look great. So, as big as this lesion is, this is what it looks like afterwards. And like I said, don't suture it, just let it granulate in and it'll be smooth, they won't even know where it was. So more cosmetic-y stuff. So we talked about excisional biopsy, uncovering a implant now or doing an ovate pontic is basically like an incisional biopsy, okay? So, you know, we don't have this, we're gonna do an ovate pontic here. We don't have like a lesion that's sticking out to remove, but we're going to create that concavity, almost like that, it's normal tissue, but we're gonna take that tissue out so we can have the lab create this nice convex pontic, or shape the tissue, you know, for the emergence of our implant, abutment, and crown. So the way we'll do this, like to do this is take and outline whatever that root of that tooth would look like if that tooth was cut off at the gum line. Does that make sense? So bicuspid, I mean, if you cut that bicuspid off the gum line, it's gonna be kind of a shape like this, right? So we're just gonna shape it like that and go ahead and trace around it. I like to make these at least 2 millimeters deep, and if I can get 3 millimeters in the interior, I go for that. And then just remove that, and then you can start to recreate papilla by shaping into a into a point on these, and actually even adjust your gingival margin level to correspond to the adjacent teeth, particularly in the anterior. So, and then when you instruct your lab, take your scan or impression of it, and if you like the depth and you got enough bone coverage and everything, just have the lab set that pontic up in there, on your final restoration, and just make sure when you provisionalize that you set your provisional up in there so it guides the healing and doesn't let it grow back. So, but that's what we're shooting for, is a nice convex ovaponic if you're doing a bridge. So another case, retained primary cuspid, and we kind of troughed it out and raised the gingival margin to make it look more, so that's the underside of it. So made that look more like a permanent cuspid where it wasn't like a short little squatty tooth. Couldn't get it as high as the adjacent or the other side, but much better. Here's a great case, a colleague of mine, Peter Pang, did. So again, patient coming in with an old bridge, black triangles. This ridge is just kind of pretty much flattened out, and he did an awesome job. This is a beautiful case. So just measured how much thickness he had, went in there and got as much ovaponic tissue reduction as possible. And you can see when he did his ovaponics, look how those papillae pop out now. It's like you recreated those. Wow. And by being able to set that up in there, it's just beautiful. It just changes. So you're not having to create long connections, you know, that make the teeth look blocky. You're getting papilla fill in between where, you know, there's no natural teeth. So it looks really good.
You've done cases like that where you go down to bone too.
Yeah. If in the anterior, I don't let the tissue thickness really guide me. If I want 3 millimeters, I think our laser erbium will do bone. So if I only got 2 millimeters of tissue, we'll talk about that after. Let me show this video, and I think I got a slide on that. So do our tracing first to a depth of about 2 millimeters. And now we've kind of got a release point all the way around it, so we're just going to use, that's a chisel tip, and just using it as a planing tool to scoop out that tissue. And then now we can sharpen the papilla, adjust the gingival, quote unquote, gingival margins if necessary. And just smooth out the depths of that ovate site.
Do you code this out as gingivoplasty?
What's that?
What do you code this out as?
Removal of hyperplastic tissue. Gingivoplasty, that code requires a perio chart, and there's no perio chart for this tooth. There's just no way, so the hyperplastic tissue is the one that works. Let's skip over that one. So this can be used for like partials as well. So here's a case I used to like to do a lot of these flanges partials in the anterior, particularly if somebody had a pretty heavy ridge, you know, and then you're bulking that acrylic out over the ridge, you know, creating way more thickness than natural, you know, that there's natural there. Because I said sometimes they don't get that anterior resorption, or they just got thick bone. So in cases we'll do a wax up, you know, get approval with the patient with the wax up, you know, even set it in their mouth, you know, to replace. And from the wax up, if they like it, we'll make a stent. And then we'll use that stent to guide us in where the, you know, bottom of the teeth are going to go, where to put the ovate sites. So do this, try it in, refine it until our ovate sites line up. And then take their existing partial, definitely reline it so it holds, it doesn't let it grow back in, so it'll hold the space and allow it to heal. And then, you know, final restoration comes in, and those teeth, without a flange, will sit up into that site. So this next case is one where definitely needed it, just a thick, heavy ridge. And you can see where the edge of the flange was kind of like digging in to cover that big old ridge. So did the same thing, did a wax up, kind of marked with the stent where we needed to go and just double checked with the stent. So those are our ovate sites, coordinating with our wax up. Relined his existing flanged partial, and this is what his new one looks like without the flange. And those teeth will set up into the ridge. So they sit like that. So he just, like I said, he just, like, this feels great. I don't have that big bulk of stuff in front of my mouth. So just another case, a double pontic. So again, recreate the papilla. And get decent looking bridge work without, with no black triangles or long connectors. So pontics, answers your question. So our goal is to create 2 to 3 millimeter deep vertical pontic site, so we can make a convex restoration. And if we don't have the tissue thickness to allow it, we do, just thick bone. So if I need 3 millimeters, and I only get 2 millimeters of tissue, I'm gonna go through the tissue down to the bone and go in and just do my ovate site into the bone. The only thing I need to do is I need to leave room to get tissue coverage over that bone. So I want at least 1, 2 is more than enough millimeters of clearance. So I'll go down on a 2 millimeter thick, I'll go down grand total soft tissue, hard tissue down to 5 millimeters, but back off 1 millimeter to 2 millimeters so I can let tissue growth in there. So when I do my pontic, my provisional pontic, I'll just trim the underside of that pontic to leave that space. And if I've taken a scan or impression the same day, I just instruct the lab to do the same thing. So, I'm ovate pontic there, relieve 2 millimeters off of the bottom of the pontic. And then when it comes back in after lab time, I've got tissue growth in there. And I haven't compromised being able to get that natural looking tooth as well.
You do that with the laser? Are you,
The bone?
are you fighting bleeding at the time that you're trying to get the scan?
Which works really good is Expasil. Have you ever heard of Expasil?
Yeah.
Yeah, use that just with a comfort cap or a cotton roll. Yeah, any bone bleeding like that, if you got it, put Expasil in there, have them bite on it. 5 or 10 minutes, it is dry as a bone. I mean, no pun intended. So, yeah, easy to get a scan or an impression. Question? So this is what I was talking about earlier. This is a technique that you can use tissue on top of a ridge to plump the ridge if it has where that concavity is from a tooth being extracted or being gone for a while. So what I did, it's kind of one of those things you start thinking, as dentists, a lot of times we are thinking about dentistry when we probably should be thinking about other things. So, but I've done a lot of the ovate ponics, taking the tissue out. Saw a couple of these cases, and I'm like, what if I release that tissue on 3 sides, keep it connected on the facial or the buccal side, and then I've got my ovate side or my implant uncovered, and then create an envelope here on the front side where that's dipped in. But now the kicker here is the laser, particularly with the HO tip, the tipless handpiece, I can de-epithelialize that tissue. So I can take it down to connective tissue and then tuck it, never gets completely disconnected, and tuck it to the labial buccal side of that ridge and plump that ridge. And it works unbelievably well. So this kind of shows, and I think I got a video that shows it too. So I just outlined my ovate site, but only on 3 sides, not on the facial or buccal. And then just sharp dissect it like we did that one video you saw, but it's still connected right here. It's not, so it's lifting up like a little tab. And then, let's see if that's it. Yeah. And then take the laser and de-epithelialize the surface, and you can tell, look at the color difference. It becomes almost like a transparent, grayish kind of transparent color when you get all that epithelium off of it. And then create that envelope on the front side of the ridge with any kind of a Woodson or elevator instrument, plump it out, and then take this tissue and fold it back into that envelope. So, and you can suture if you want. Really with periacryl, there's no reason to suture. I did a suture on a couple of these cases, but now with periacryl, I would just tack periacryl in the corners, put a provisional in place, and that'll hold it. There's no way that it's gonna come back up. Plus, once it clots in there, it's kind of the stickiness of the clot too, so. So, in final restoration, so we've got, looks more like a root form in there now rather than an indentation. So here's one in the anterior. We did, I think this was uncovering an implant. Yeah, so we did it, just took the tissue over top the implant, did the same thing, put our temporary abutment in there, put a temporary on it, and took that tissue and plumped it out here where it was indented. So just to get a little bit better. And again, coating wise, it's a connective tissue graft. It is. I mean, it's just we just didn't free it. It's connective tissue graft. Just going and sizing three quarters of the way around this, keeping the marginal gingival and adjacent teeth intact.
Couple millimeters of depth, you said?
Yeah, just 2, no more than 3 probably on this, so. At split thickness, you're going down, you're not removing periosteum, but you're going down to the periosteum level. The other nice thing about the erbium too is if you are doing implants Particularly if you're doing subcrestal type implants, a lot of times you'll uncover those things and then they've got bone growing over the top of them. And this takes the bone off and does not affect the implant. Remember the reflection? So the smooth implant surface, it doesn't modify at all, but you're not going to risk scratching or messing up your implant with it. So very slick. So and that's part of uncovering this is we cover the implant, just put a temporary abutment, we'll make a temporary crown for it, let the tissue heal. So now just kind of create an envelope up in there that we're going to put that flap.
Are you going down to bone there, or leaving the periosteum?
Periosteum's intact. Yeah, just between the periosteum and the epithelium, I'm just squeezing that connective tissue. Just tucking it under. So it's tucked.
So now you just answered that question, but periosteum is attached to the bone.
Yes.
You tunneled right between that, and then you tucked that tissue in between.
Yes.
Okay.
After de-epithelium.
Yeah, took the epithelium off though.
Yeah.
So with the erbium, particularly the tipless handpiece, you can just air braid it right, just airbrush it right off until, and I mean, just use very light water so you don't damage, don't going to heat it at all, and just move it until you just down the connective tissue. Versus trying to do it with a burr or something, you could have caught up. That's one nice thing you do a lot of surgery with the laser is it's end cutting. So your flaps are way more conservative. Everything's conservative because you don't have to get that flap into the next zip code, so you don't catch it in a rotary instrument. It's a non-issue. So rarely do I when I do any kind of osseous crown lengthening and stuff like that, rarely do I ever flap beyond the mucogenital junction. So I'm not worried about air emphysema issues. I'm not worried about catching my flap or tearing it up or anything, because it just won't do it. So this is where periacral would come in better in the suture now. And then, then I just made the provisional and let the graft heal. So.
How do you know when you're down to connective tissue? Is it
Color change, and typically if it's still connected, when you're abrading away the epithelium, you're really not getting any bleeding. When you start getting little pinpoints of bleeding, you're in the connective tissue. So, and that's the same thing have you done any pigmentation removal yet? Like melanin? Same thing, that's how you know, well, how far do I go? Well, you'll see the pigment, number one, you see the pigmentation, melanin pigmentation go away, but you'll also start to see pinpoints of bleeding, and that's coming from the connective tissue, and that's when you stop. You don't do anymore. So you're at or beyond the basal epithelium. So again, here's another implant case. It's kind of three-sided. Lots of attached gingiva to work with. So they're three-sided. Reflected that. Got to our implant. Removed any bone from around the implant that we needed to get the cover screw off. Put a temporary abutment in there. And then with our flap that we have, that's kind of what it looks like when you de-epithelialize it. It's kind of a white, transparent. And then made the envelope, tucked it under. Said periacral would work great, and then made a provisional. And then about 3 or 4 weeks later, permanent comes in. And just instead of throwing that tissue away, use it.
What are you using to de-epithelialize?
HO2 handpiece, the tipless handpiece. Yeah. You could use the H14 with the chisel if you want, but I just like that. It just gives you a nice even, you just brush it away. Okay. Let me show you a couple more quick things. Oh, real quick, some little cosmetic, and then I'll show you something as far as mucocil removal, touch on some perio. Yes, and then we'll look at some photobiomodulation, and just kind of touch on night lays a little bit, because I think we're going to try to do a little night lays on you, Doc, right?
Yep. Thank you.
So Okay, so, these are really cool to get if you're doing a lot of cosmetics, tissue recontouring,
Where do you get those?
hue free. Hue free. So what they are is the first gauge that looks like a cross will give you the ideal width to length ratio of the centrals. So if you're doing, say, post-ortho care, where you've got, a lot of these kids come in and they've got square looking teeth because they had hyperplastic tissue during the ortho and it doesn't all go away. And they'll have, their teeth will look square, but they've got some great enamel, and the CEJ is way up underneath there. So this works good for that. If you're doing any kind of open flap or mini flap surgery, that's what this is for, is to be able to measure where your soft tissue height is, and then when you flap it back, the corresponding color on the longer axis is where your bone height should be. So it gives you the biologic width, you know, without having to close it back up and everything. Their probe is flat, angled, so when you bone probe, you can run this right along the front of the tooth and decreases the risk of bypassing a ridge and going up into the vestibule. And it's marked at 1 millimeters, 3 millimeters, and 5 millimeters to correspond. Minimal gingival pocket depth after you do gum recontouring should be 1. The normal average biologic width is 3, but the interproximal biologic width is 5. That's why they got those numbers on there. So using a gauge, so here's a case coming in, chief complaint, square looking teeth, look too square. So we took our gauge, rested the little stop on the incisal edge, and just look at, okay, where does the width, because we're not going to change the width, where does the width correspond on this color scale? So it's really kind of on the outer edge of the red. So our ideal zenith position, or height of contour, should be about the top extent of the red. So I'll mark that with a perio probe, and that's my ideal height that I'm going to try to create, unless that height puts me on the root surface beyond the CEJ, then I can't do that. So your limitation is the CEJ. So I kind of feel up underneath the tissue for that CEJ, which was pretty close, maybe a millimeter shy of that. And then we can start to contour. We can use a laser to shape and contour and finish that to the ideal. And so we're at the CEJ. This patient has some beautiful tooth structure, just hidden up by that pink stuff that's in there. So, here's a couple other cases, just fat. And the other thing with the tipless handpiece too is on these cases, not only can we round up this architecture, but in these areas where it's puffy papilla, we can do a 3-dimensional reduction on it too. So I'll use like the chisel tip or one of the tip handpiece to do my gingival margins, but I'll come in with the HO2 tipless to thin the papilla so where they're puffy. You can kind of see the areas. Here's the case when we raised it, the frenum. It was getting a little too close for comfort, so I treatment plan moving that out of the way. So another case of asymmetry. Look for these in your hygiene departments, because this is funny. These patients, I've had several of them come in on hygiene, and I'll be like, you ever notice that your one front tooth looks different than the other one? Give them a mirror. No, I never noticed that. Oh, you're right. Wow. You know, and I'll be like, well, which one do you like better? You know which one they're going to answer. It's number 9 is much better. You know, do you want to do anything? But oh, I don't think so. Well, you get within a week, you're going to get a call because they cannot stop staring at themselves in the mirror. It will drive them crazy, and it's such an easy procedure to do. I mean, it takes minutes to come in and just balance things off for them. You know, and this, you know, one tooth wasn't worn down, it wasn't damaged, anything else. It just, for some reason, I don't know. Maybe this, you know, a lot of times what happens. That tooth might have been palatally positioned, and when that happens during eruption, the alveolar bone and the tissue tends to grow down more on it. So even after orthodontically it's moved out into the proper position, that improves, but it doesn't always go away. So that would be my guess, is this is a post-ortho thing, and this tooth was probably crowded out to the palate at one time, and they got it torqued in a position. So again, hyperplastic. You know, I give these patients about 6 to 8 weeks of good brushing and flossing if they'll do it, and then by then, it's not really going to go anywhere, so we'll bring them in and recontour and shake the tissue and get their teeth uncovered.
When you do that, do you have any undulation or is it just perpendicular? You just do the test on.
Depends on how much tissue there is. So if I can, I want to stay parallel with the tooth. Unless I'm doing ceramic, then it doesn't matter because I'm going to put ceramic on it, because I don't want to etch the tooth. So, but if I have, I don't know if I show it, but if I have a super thick tissue that's got gobs of tissue like that, it can take forever to do it that way. So those cases, I'll do it perpendicular. Most of the time they're ceramic cases, and I'll just make sure I don't go all the way through and use a scaler to kind of peel it off as I get most of the way through. Yeah, and it's just time savings, because I said you'll be there, all day long the other way. So, but if you can do it, if you're not going to do ceramic, try to do it parallel with the tooth. Since we're end cutting, so it's an end cutting, so there's no side cut. So it's just, if you're staying parallel with the tooth or the root or the crown, you're not going to get any etching of the enamel at all. So, because there's minimal or no divergence of that laser beam coming out of the end, it doesn't do this. So with our tips. Let's see, just exposures, get through. Transeptal fibrotomies, I do those with the laser. Patients enjoy those much better than a scalpel. So this one I want to show you. So here's the third type of biopsy. So like a mucocele, by this. Well, let's go back. So if you do it, I think Chad had good luck with this. But if you do this, some people it's like a cyst or a mucocele full of tissue or blocked up or something causes it to back up. You can go in and just puncture a hole in it and drain it. And what I've read about these things, or had read about these things, is you're higher than likely chance you're going to have to do this multiple times because it'll come back. So I'll show you a trick that I tried and it worked to distinguish. And the thing about these things too, you can't distinguish them from normal lip tissue. So if you open these things up and you just start digging out tissue, you don't know really what you're getting, and you can end up creating a defect or something that doesn't heal. So what he's doing is just taking, I think it's a chisel tip, it looks like, and going to puncture through, and you'll be able to see it. It's just like a brown, yellowish brown, viscous fluid. And I think you hear it with the suction when it finally gets through. You hear that right there? That he got through it, and the suction kind of got all that. Now he's just going to squeeze all the excess out till he gets bleeding. And then he hit it with some PVM. So he's using his 300 fiber NDA to do his PDM on this. And he's moving it, and we'll explain that with PBM. So unless you're using the Genova or the Marco hand pieces, the light energy, the laser energy is not even throughout the whole dot or spot size, so you have to move these tips, the fiber or the R30 handpiece, which I know they got upstairs. You have to move it around to even out the dosage. So with your Marco or your Genova, it's basically you set it into place and do it, and it's this perfectly even, influx of laser energy. So I had a couple of these come in, and what I decided is let's start off the same way. Let's create a little puncture in it, little hole, and then I wanted to be able to define the borders of this cyst or mucocele. So I came up with using a thin mixture of alginate. It's very hydrophilic, and through the hole I made, I took an irrigation syringe with something a little bigger than like the black ultradent tip that it would flow through, and then put the tip in there and just slowly started squeezing, and all that fluid came out, and eventually my alginate came out. So walk away, let it set for a good 5 to 10 minutes, and then now you have, basically you've taken this balloon and filled it with alginate. So now we'll go and we'll start to do a little bit of an incision, not all the way through to the alginate. I'll kind of cut through a little bit and then start to squeeze that ball of alginate. And if that doesn't do it, I'll do a little bit more, but eventually what happens is it starts to bulge out, and then just start broadening your incision until you get it to the point where you can squeeze that out, and it brings the whole lining of the mucosal out with it. So that's the ball. That's when it comes out. Sutured it up. That one, and it's just this thing has a thin lining all the way around. It looks like a brain, doesn't it? Yeah, like medulla oblongata. Medulla. So here's another case. I see all my patients have them on the lower right lip. I have no idea, and even Chad's was like, it's weird. So again, little puncture hole. Squirt the alginate in. Wait till it comes out. Let it set. Just break off that little stem and just take like a chisel tip or whatever, and just do like a incision line, and then just start squeezing. And when it starts to bulge out like this, don't go through anymore. Just kind of widen your incision and keep squeezing it until you create enough of an incision to squeeze that out. And then you're able to finally grab it and then kind of detach it. And then this one even picked up some of the ducts. You see those are some of the ducts that flowed into it. So the alginate is so hydrophilic it will just replace all that fluid. So after it's out, this I will suture. Just kind of fits right back together. So after about a week, and that's the size of that one came out of it. Yeah. So I have never, knock on wood, I've never had any of these come back. So, but I'm pretty confident I've gotten the majority, if not all, of the mucosal out of there. So, and then how many times do you guys see these things? So if not hygienists, look for these things, because you may have to dig through about 5 layers of lipstick on your female patients. So, but yeah, these don't go away. They're like blood blisters that don't go away. And from what I understand, I've had patients that have asked dermatologists and stuff, and they're, talk about having to cut them out of there and stuff. Well, that's insane. Our diode and our NDA lasers work great on just eliminating these. These are vascular lesions. Laser energy is absorbed by that vascularity, so you can go in and literally seal off the feeder vessels to these. And then some doctors, they do it 2 different ways. Number one, if they want to do it without anesthetic and possibly multiple appointments, they'll take a glass slab. Energy goes right through it, right? There's no chromophore. And they'll put that cool glass slab, like a cold glass slab on a lip, and they'll treat it until that lesion turns kind of like grayish purple. And actually, a lot of times they're convex and they'll actually suck in. And then they'll let the patient go, tell them to come back in about 2 weeks. And typically it's smaller, and then they'll treat it again, and then it'll go away like that. I've always just one appointment where I will do that, and I'll show you a video that shows it. But then it's like I'm sealing off the feeder vessels, and then I'll go in and I'll dry up the pond. And then they don't have to come back, they're done. But you do have to use anesthetic a lot of times in those cases. So this one is using a diode. And uninitiated tip, which means clean tip, I want the laser energy to go into that lesion. So I'm just going around the periphery and watch what happens to that lesion after like 10 seconds, 15 seconds. You get that kind of gray. And the lesion actually reversed, it's sucked in. So it's not domed out anymore, it's sucked in. So once I've got that, stop for a second. If it stays like sucked in like that, then I know I've got the feeder vessels pretty much sealed off. And then now I'm going to go and drain the pond. So I want, since it's a diode, I've got to initiate it. You don't necessarily have to do that when in the egg, but a diode you have to initiate it to trap some of the heat at the end. And I'm just going through that tissue until I get down to where the pooling of blood is in that lesion. You'll see it in just a second, right there. And this one actually had two compartments because I was just kind of drying up the first one, and in a second, I got a second one right there. So. If there was any more left in there, my assistant just got it. Something dry. So I just went around it until all bleeding stopped, everything was dried up, coagulated, sealed. And then just patient keeps that moist. They can use the vitamin E, they can use some kind of a lip balm if they want. But I mean, vitamin E works good. And just have to tell them, I said, just for about a week to 10 days, you're gonna have kind of a scab there. It's gonna go smaller and smaller and smaller until it's gone. And that was the case. That was this guy here. Yeah, so you can see right away, this is what they kind of deal with. It kind of slowly goes away. There's two of them on his lip. And in about 2 to 3 weeks for sure, there's nothing. There's no scar, there's nothing. So you can find these on the tongue. So there's a couple of cases where same procedure, maybe a little bit more energy for a little bit more time because it's a bigger lesion. And this patient came back like 6 months later. I just remembered, or both of them did, came back and just said hygiene. Hey, let me get a picture. And just, where was that thing? I don't remember. So, okay. And then even you get larger ones. This is kind of a story. This patient came in with this large one, this big, had been in there for about 20 years. Somebody, an ENT, talked to her about dissecting a part of her tongue, but couldn't get rid of it. You can see why it's in there for 20 years. So and I knew this was going to be 2 or 3 treatments. So just made sure it wasn't arterial, wasn't pumping or anything, it blanched. And we went in and did the same thing, just again, a little more energy, a little longer period of time until I got that color change. I drained it. Told her to come back in a few months. Came back. Finally, when she came back, it was about that big, and it's like, well, that's about the size of those other tongue ones that they showed you. This makes it easy. So did the same thing, treated it, drained it. This was a material called HemeCon. It was kind of a stop bleeding patch. And so she came back in about a month, looked like that, really completely gone, not visible, and I think she called a couple months after that and said there's no remnants of it at all. So this is pretty amazing what these lasers can do in some of these cases. So real quick, if you run across with herpetic lesions, best way is we'll talk about PBM, but I usually hit these with PBM for about a minute, and then I go over with the laser. This is the same for aphthous lesions. So either tipless handpiece or chisel. High suction, have good KN95 mask at least. So, and then just kind of do the laser band-aid thing on them. And then I used to do it and wipe it with wet gauze, and then do it a second time and they're done. So a combination of NDA, PBM for a minute, and then surface treatment with the erbium. And I had that done on an aphthous I had, like my first aphthous ever. And it was about 2 days old, and they did that, and immediately any discomfort went away. And by the next day, I didn't even know it was there. It cleared it up like within 24 hours. So, and they say, if you get these in the early stages, either where they're tingling or where they first break out, you can get this out of about 5 days total time from start to finish. I'm going to hit on some perio here. Kind of quick overview of what we're doing, but really, if you have a chance, Dr. D'Alessandro does great great teaching on salvaging implants, treating affected failing implants in with the perio. So what we're trying to do, this is called what Fotona users do not do LANAP. Okay, LANAP is Millennium. If you're familiar with it, it's Millennium. It's patented. If a patient calls you up and says, "Do you do LANAP?" and you tell them yes, then what I understand is they've got a good legal department. They'll come after you, really. But they could say laser-assisted new attachment procedure, or what Fotona calls it is twin-like. It's basically we use Nd:YAG and erbium in a combination to get us the results that we want. Millennium only has an Nd:YAG laser. That's all it can do. So what the whole concept is to go in with a laser, the Nd:YAG, and use it because it loves hemoglobin, right? It loves blood, so it's very attracted to it. So as a chromophore, and to use it to basically slough the inner lining, the disease lining of the pocket, and then go to the erbium and use it to detoxify, scale the roots of the teeth along with heme instrumentation. But we finish with the erbium because we want to get rid of the smear layer so we have a better opportunity of getting true attachment, not long junctional epithelium. And then at the end of the procedure, after that's done, we're going to create, because we can take our erbium is a bone cutting laser, right? Nd:YAG is not. So I don't know how Millennium gets by claiming an osseous procedure when they're not using any instrumentation that is qualified to work on osseous. So, but our erbium is FDA approved to use on osseous. So as we're cleaning the root of the teeth and doing a smear layer removal, we're actually taking the tip of the erbium and going all the way down to bone level and we want bone bleeding. We're kind of etching the bone and we're getting bone bleeding. We're not doing gross removal of bone. And then with that bone blood coming out, we're going to use our Nd:YAG at the end, and we're going to form a nice clot that we seal in there with pericryl. Okay, so which gives us about a 5-day barrier, so we get reattachment of this connective tissue attachment, epithelial attachment, mainly connective tissue attachment right in this area. So let's go through. So clinically, we're looking for red inflamed tissue ideally. Bacteria are also black pigmented anaerobes, so our Nd:YAG is attracted to them as well. So they're into the cementum and tissue. So let's see. So our goal is we want to destroy the quantity and quality of the bacteria. We want to deepithelialize the pocket to remove the disease or inflamed tissue. And we want to prevent the epithelial downgrowth in its attachment to the root surface, because that's a very unstable attachment. So we also want to penetrate into the cementum, kill the bacteria, and remember that our endotoxins are also in the cementum, and we've got to remove those as well. So, and we want to minimize damage to healthy tissue, and that's where the Nd:YAG comes in, particularly if you've got red inflamed tissue. It will do a great job of distinguishing between the two. So, and we want to stimulate regeneration. So our first pass, as I said, we're going to use the Nd:YAG, okay, and the purpose is to remove the inflamed disease epithelial lining. We're gonna create hemostasis for better visualization. It'll help define tissue margins, perceiving or mechanical. And what it also does is when you're in there doing that, it opens that pocket up for you as well. So you have easier access with your hand instrumentation and your Cavitron and your laser tips. So actually, when you're done with the Nd:YAG and even say the next step with the erbium, you've got a pretty loose flap. It's not released at the papillas, but it's a pretty loose flap that you can see with magnification. If you work with magnification, you can see down there in a lot of areas to see whether you got the roots clean, which is really cool. So, and some of that comes from thinning of the flap by getting rid of that inner lining, but some of it comes from the erbium stretching that tissue out a little bit as you're doing the scaling. So, yeah, that's what I talked about, yeah, releasing tissue tension, and then selectively removing the epithelium from the connective tissue. Your settings, if you want to take a picture of these for your Nd:YAG. So we're going to be MSP. So whenever we're removing tissue or basically not doing coagulation, we're going to be on MSP. So you'll see when we do coagulation, we're always on VLP, which is, again, longer pulse. Creates a little more heat, coagulates. So 20 hertz, 3.5. This you can tweak. So if you got that really inflamed patient, you may get by with 2.5 to 3 watts. But if you got that patient, say, that comes in that's a smoker, that has perio, but their gums are just pink as all get out and look like calluses, 3.5 isn't going to do anything. You know, you may have to go as high as 4.5 to 5. So typically go in, and what you want to see is when you go in, you do your little strokes in the pocket. So, and the other key thing with it too is when you have the little white cannulas on your machine, you know, on your fibers. Yeah, so if you use those cannulas, they work as a nice depth gauge. So always set your fiber depth 1 to 2 millimeters shallow of the pocket depth. So if you got a 6 millimeter pocket, you want to be about 4 millimeters of your fiber sticking out of that cannula. So then when you're doing that, you can see when the cannula hits some gingival margin, you knew you're 4 millimeters into that pocket. So start in an area, let's say like a second molar, and what you want to see is after you do a few swipes in there, you want to see some coagulum, some buildup on the end of the tip that you wipe off, and then you know you got the right setting. If you're in there nothing, and like again, it's real pink, tough gum, then you might want to bump it up a little bit and try it again and see. So the other nice little adjunct is, you're familiar with the Mr. Clean Magic razors? Yeah, use those? Yeah. They work great for cleaning tips. So, and it'll save you from having to, if you use that, what I did is if you got some old Crown and Bridge boxes around, take those, cut those erasers, put them in a box, and it's kind of a, you can make it display. Sometimes I got so many, I would throw the whole box away because I had so many in a drawer. But after you do it, as soon as you see a little bit of that buildup, clean it. Because if you wait too long and it cooks on there, then you got to cleave your fiber. So, so you want to be able to get through a quadrant or two of this without having to cleave your fiber 10 times, maybe once or twice max. So second is the erbium debridement. So we're going in to clean the roots of the teeth, this H14 handpiece, because you want to use the tip, and you can use a 600 micron tip, which is the yellow, the amber colored one. It's just a straight one. So about 20 hertz, QSP. Okay, we don't need to be SSP. QSP takes this pulse and cuts it into 5 smaller pulses. So it gives you the same amount of energy going in, but it spreads it out a little bit, so it's not as aggressive to the root of the tooth. So what your goal is on this is that tip will give you very good tactile sense. So as you're moving up and down that root, you can feel the calculus, and you should, if you feel it, you should feel like, kind of pop off of there. So we want to do that. So those are the settings. And then, so calculus removal, 600 micron, 50 microsecond pulse, but really they've gone to the QSP. Yeah. QSP is what we want to go with this machine. Okay. And then, so the third step is hand instrumentation and Cavitron. Don't, continue to go do that again. Okay, get in there and clean it the way you typically do, small scalers, whatever you need to do to make sure everything, and then you also get the tactile sensation of the root of the tooth too, to make sure you have everything off. So, as I was saying earlier, whenever you use hand instrumentation or Cavitron or piezos, you're going to get smear layer in the root. So what we want to do next is second pass with the erbium YAG, and you guys should have a radial firing tip, or the one that looks like a pencil. So, and that's what the ideal tip to use for that. It's a quartz tip, so it's going to be the yellow-brown, but at the end it does this. And what it does, it's the only tip we have that will create lateral type of energy release. So it creates almost like a bubble of energy. And the settings are really, really low, and you're going to go and just basically work that up and down. Literally, I want you to touch the bone with it, all the way top to bottom of the pocket, tapping it off the bone. So if you don't have bleeding going on from your ultrasonics and stuff, we want it at this stage because the next step is to form the clot. So we're going to use, see if it's got the thing, yeah. So forming a clot, again I said VLP, which is our clotting setting. Pretty much the same settings, 20 hertz, 3.5 watts. Don't worry about the timer on that. And you're going to go into the pocket, use it again about a millimeter or two shy of the depth of the pocket, and just turn it on and just withdraw the tip out of the pocket. And you should, what you'll see is if the pocket's bleeding, you'll get like a bubbling of the blood and it'll turn that purpley color. So do one side, do the other side, and then move on to the next. And if you don't have an assistant, you got to do it yourself. But if you by chance have somebody who can help you, as you move up the side, they can take a wet Q-tip and just lightly press that tissue against the tooth. So as you're clotting, or right after you clot it, it has that stickiness. It'll stick against the tooth. So you get to the front of it, everything's kind of stuck together. Then you can take your, I think it talks about it, your periacral. Yeah, fiber prop. Yeah, and then take your periacral in a pipette. If you guys don't have the pipettes, they do. Use the pipettes, they're so much easier. When you use a micro brush, you'll get like one sweep, and then the next time you do it, it sticks to what you put in there and pulls it off. It drives you crazy. So if you have a pipette, you can suck some out of that bottle and just flow it around there. And then just don't spray hard water, just drip water on it. That helps it set. And then take some, you can use the vitamin E again, you can use lanolin, any kind of agent. Once it sets, just rub it over that with a Q-tip. Because even though it's set, a lot of times it has stickiness, and a patient's cheek will be glued to the periacral. So, so the Vaseline will help keep their cheek from sticking on it. And then usually when you do this, you want to do one side at a time, and you really, really, really press the patient to eat on the opposite side. So one of the problems Dr. D'Alessandro said he had was it felt so comfortable post-op that patients are walking out and they're, if it hurts, it's reminding them, on this side, it wasn't hurting. So he was starting to use PerioPack a little bit as a, I hate PerioPack, as a reminder. But I mean, if you can really instill in your patients to, hey, for the next week, left side, left side, left side, don't eat on the right side. And then opposite when they come back. So, but really, I mean, what you expect, minimal swelling nor pain after surgery, which is wonderful, but it's a detriment sometimes. No persistent bleeding of the soft tissues because you've clotted. So patient walks up front. My team used to always love that after we got done with a procedure, when the patient comes up to pay and they're like, just spitting blood over the front. They get so pissed off at that. So resolution of inflammation starts immediately. Flora is changed to one that's biologically tolerated. The tissue's pink and tight. And then radiographic changes with time. So you're not going to bring the patient back in a month, and all of a sudden, like, wow, they've got all this bone growth. But it occurs over the period of up to upwards of a year. You know, see slides where that's doing better, and it just keeps getting better. So.
Do you do PBM with that, or there's just not really?
Yeah, do if you want to do PBM with it, actually do it before you do the clotting. Okay, because we're talking about PBM will cause vasodilation. So a lot of cases, even with a socket, extraction socket, you do all your clotting, and then you hit it with PBM, it'll start it oozing again. Because it vasodilates. So if you want, go. I would say within 2 weeks. Yeah, definitely 2 weeks. Yeah, they just really need to, for about a week, they need to really heavily favor the opposite side, because you're getting a reattachment, but it's very weak, you know. And even after they recommend, you do this procedure, don't probe them for 6 months. You know, don't probe. I know you just like, let me see what I'm doing. Hold on, hold the reins back. Don't probe them for 6 months.
Is this the same protocol for periimplantitis? And
Periimplantitis is a lot different because the settings are to not modify the implant surface, to detoxify it, but not change it structurally where it won't integrate. So there's no indie egg around a implant. Indie eggs will, try it sometime. You'll get a big spark and it'll be a little melted area. It'll melt the implant. So ND egg, no. The only laser that's safe around implants is erbium, and even that is, if you're cleaning those, it's like multiple passes per thread exposed. Typically, crown comes off. I mean, you got to have 360 degrees to be able to get it. Do your flapping, and then it's multiple passes per thread, and it's like energy levels of like, I'm trying to think, 30 hertz, and it's below 100 millijoules. It's like 30 hertz and maybe 70 millijoules with a bigger tip, the chisel tip, or they make a big round cylinder that works really good. Because even some of the smaller tips, we tested them on implants, and for instance, that radial tip I was talking about that's like spreads the energy out, it modifies the heck out of an implant surface. It's insane. So, but there's 2 different tips, but Alan does a whole day course on it. Okay. So, I mean, it's you know, and he talks about everything from a standpoint of, you know, like, yeah, you treat one of those implants and it's not yours, guess what? It is yours now. You know what I mean? That kind of thing. So, okay.
So, you can't probe for 6 months, does that mean they should?
No, they can come back and get a, yeah, they get a prophy.
Okay.
Yeah, you're not, don't subgingival scale or anything, but bring it back, get them, you know, back, it was like a prophy type of, so.
Not 3 months, like, the maintenance is usually 3 months later?
I mean, I think 3 months is fine as well. You just don't want to probe for 6 months. So, but yeah, keep everything super gingival.
For how long they shouldn't do dental floss?
Usually for about that 2 weeks. So about it, if they're coming in for the other quadrant, when you send them home, you can say, okay, now you can start to gently floss, you know, so, you know, the other side. So keep it off, keep the floss out of there for about 2 weeks.
2 weeks.
Yeah, because you don't know if
What
they're.
about water pick? No water?
No water pick.
Just
No.
brushing?
Yeah, brushing. Yeah, no water pick. Again, for a couple weeks. But if it's adjustable, turn it on the lowest setting and start with that, and then you can bump it up as time goes on.
Earlier, when I think that the dentist starts with procedure, then
The dentist does the tissue removal, so number 1 step.
Which is within 300?
Yeah, which is 300 fiber, because you're tissue removing. And I don't think there's any state that allows a hygienist to do tissue removal. So, is there a question? You're welcome. photobiomodulation. So, you got a laser, you've got some kind of chip that can do this. So you can do it with your ND-AG fiber. You can do it with an R30 handpiece, and the Marcos, as you notice, are set up. They're designed basically for doing this. So, why do we do it? You can use to reduce pain, speed healing. It's used in a non-thermal radiation level to stimulate tissue. So patients shouldn't feel warmth or feel like it's going to burn them. They really, sometimes if they feel the slightest warmth, maybe, but really they don't feel much of anything. So it used to be called low-level light therapy or biostimulation. It's great to use post-operatively, post-extraction, post-long appointment. For TMJ, for masseter type discomfort, potential. It aids the healing response. We use it for oral ulcerations like aphthis, hepatitis, and like I said, just patients come in that you're dealing with TMJ. If you treat TMJ, it's a great adjunct to help them out as well. So, and you were talking about paresthesias too. So, infraocular block or post-extraction, something like that, it works as well. I've seen it work on Bell's palsy patient. So I actually did a lot of stuff out of LVI, and Bill Dickerson's wife Heidi came down with Bell's palsy, and one of the lab guys came down with it almost like within weeks of each other. It's kind of weird. She treated every other day with a diode laser, which again, and within like 7 to 10 days, her Bell's palsy was gone. The lab guy, last time I saw him, he's still he's paralyzed. He wouldn't do it. He's like, come on. He just wouldn't do it. So, it's worth a try. And typically when you do it, if you do 2 or 3, 4 sessions, if you want to look, the patient's response should be something. How's it feel now compared to last time? It feels better. If they're like 3 visits in and they're like, I don't feel any different, be done with it. Don't keep wasting your time. So, they should be getting a response. So how does it work? Mechanism active cytochrome oxidase absorbs red or near infrared light. That's why even the red pointers work. Just a depth of penetration. And it creates ATP, nitric acid, and reactive oxygen. So remember the Krebs cycle, which we all get nightmares of. But this is basically how it does. Light energy goes into the mitochondria, and they produce ATP, reactive oxygen, and then nitric oxide. So it stimulates the healing, reduces the inflammation, so inhibits A delta and C fibers. It stimulates lymphatic flow. Some of the instructors that I work with, with long appointments as well, they even not only treat the master, they'll treat the lymph as well, particularly post-extraction oral surgery. And they say they get great results. The patients just minimizes their swelling, any kind of swelling, and just their pain. So if you're into trigger points or acupuncture type stuff, you can use it in those areas as well. It's shown to work. Also, NDA laser does influence or does retard the growth of yeast in Canada and Streptococcus. So just let me see, go through. Yeah, so these are some of the lasers as far as their depth of penetration. And it all has to do with their chromophore, with the chromophore water and the reaction of water. So again, NDA penetrates as deep as this because it just doesn't react. It's really low on the water curve as far as absorption. But as we go up the scale, we get the CO2 or even the erbium, it only goes a few cell layers deep because those lasers just get sucked up by the water in the tissues. So this is what I want to talk about too. It's important when you're dealing with photobiomodulation is we do not want to do it every day, okay? We want, what they've shown is every 48 hours because you get a positive response up to a certain point and then you start to drop off. It's kind of like taking an antibiotic. There's a certain dosage of antibiotic that's good for you, but if you go and take half the bottle, it's not really good for you anymore. you know, so you could overdo it with this. And I think that what they talked about, it has to do with the reactive oxygen, you know, can become toxic at too high levels.
For how long do you recommend? 1 minute?
Typically, the way it's broken down is 1 minute per site. So, and the number of sites depends on how much area you gotta cover. So if I got a sore knee, you know, I'm not gonna do one spot here. I'm probably gonna do 3 or 4 on one side, 3 or 4 on the other to cover, you know, the tissues.
If you
So,
do, for example, the TMJ, just with the Marco, just 1 minute. That's it.
yeah, really. I mean, the Marco's big enough to cover the whole TMJ. Now the masseter, maybe 4, maybe 3, you know, to hit that. So particularly if you're, you know, and even if you're doing one of the ones that you have to move around, if you're trying to do too big of an area, you're really not dosing anything deep enough. So you want to stay in about a quarter spot and just work, you know, kind of the same area that your Marco would.
And with the Marco, you can touch the.
Yeah, you can flat top, yeah, because it's spaced, it's
spaced,
set
yeah.
back, yeah. Yeah,
And
you-
with the Genova, you have to give a little bit of space.
Yeah, you wanna leave a little bit of space, but your Marco's got the little cage on it,
Yeah, that's good.
just put it right there, hit the button, let the timer count down.
And with the Genova, like, how far?
To Genova, I would probably, about the same distance as, I don't know, maybe a centimeter off the tissue.
And with the like you talked about 48 hours, so like, how do you, like, do you always, is it always 48 hours? Is it sometime once a week, or like, how do you?
You can go, I mean, your best setup is to try to do, I mean, the way if we work Monday through Thursday, we can't do it every 48 hours. So it might be a Monday and a Thursday, you know, twice a week, and then the next Monday and a Thursday.
Oh, like 2, 3, or just depending
Yeah,
on.
I would really depends on the response they're getting.
Okay.
Yeah, so, I mean, if you got somebody comes in with TMJ pain, and, you know, maybe get them in a splint, but they're still having pain, treat, see them, you know, treat Monday, see them on Thursday, how's everything feeling? Oh, it feels a little bit better. Good, treat it again. Like I said, you get 3, 4 treatments, and they either basically bottomed out where they're not getting any better, or they may not get better at all from the get-go. Just don't do them. That doesn't, I mean, nothing's guaranteed to work on everybody.
So when you do prolotherapy in the TMJ, so can you do you do the laser before or after? Or it doesn't matter?
To do what kind of therapy?
Prolotherapy?
Prolotherapy?
You know that they do those, the glucose they inject,
Oh.
and sometimes they do the stem cells, the liquid, or the procaine, or lidocaine.
Yeah, I know what you're talking about.
Or a lot.
Good question, I don't know. I don't know the answer. I've
So
never.
the laser shouldn't affect
Shouldn't
the
really,
medicine.
no, it's not
like
gonna,
the
it's not gonna,
procaine.
it's not gonna affect the medication that's in there.
So better, before to promote circulation or after?
My guess would I do it first.
First to
Yeah,
promote
yeah, I would
circulation, and
do-
when you inject.
yeah,
then,
I would do it first, but, so that's a good question, so, might be something to ask. Ask Steve Pullhouse, cause he's done a lot of the timing and the numbers on this. So, important to get the right dosage. There's no university accepted standards for photobiomodulation. And then what they found is, just from studies, is the ideal dosage for wound healing is between 2 and 10 joules per centimeter squared, which puts you kind of right in the middle of this graph right here, as far as response. So if you take a quarter spot, quarter size spot, and you do your circle, it gives you right about that 6 joules per centimeter squared. So, and just for, keep your times 60 seconds or less. And yes, it is possible to overdose on light. So this is our fiber, our diode fiber, our ND-egg fiber. So 5 centimeters squared is about the size of a quarter. This is one of the, that's a small Marco. So that's what it should look like. And you're just like going to treat just in a circle in that area, move it around, just hold the fiber in one spot. Because you'll get heavy dose here and you'll get low dose on the outside edges of that quarter size. So the R30 and the 300 fiber is moved in a circular motion to even out. Because that's kind of how the energy, so your flat tops like your Marco are just this. Boom, everything's perfectly even. but your 300 fiber is hot in the middle, hot being more intense, and it tapers off on the side. So to combat that, we need to take that dot and move it around for the minute. So this just shows the intensity Gaussian beam, much redder in the middle, and then your Marco, or your, what they call the flat top, is pretty much perfectly even all over. So that's, yeah, this is a picture I was talking about. It's just that one they got up there, it's like, oh my God, it doesn't look that big on that picture. That's huge. So how many of you have, do you guys have, let me see, this chart here. Yeah, take a picture. This is one that Steve came up with. It's going to tell you your settings based upon, based upon the tip that you have, and it's breaking it down. So surface would be lichen planus, aphthous, herpetic type lesion, something that's, and then deep would be your like deep masseter muscle or TMJ. And then if you want to go really deep, like treat something outside of our realm, like a shoulder or a knee, you're just going to up those numbers. You're going to up those numbers a little bit, but he stayed try to within the dental end of it all. So, but yeah, just treating treating different inflamed tissue, aphthous type lesion, herpetic type lesion. So again, non-thermal, non-ablative energy, just pumping in. We're getting mitochondrial stimulation, getting fibroblast proliferation, increased collagen synthesis, enhanced leukocyte phagocytosis. So, and we see it with increased postoperative comfort, minimal edema, rapid healing. So just, yeah, we'll play around with it. With we got one of the tips up there. We got the R30 up there too. So let's see. What's that? No, I don't think so.
Can you touch a little bit on, I know you talked about maybe doing some night lays, maybe that's where you're gonna go, but I know I've heard a couple, like there's the technique, like I learned, then I learned from someone else a different technique, so I'm always curious about technique,
For night
and
lays?
settings and all that stuff for night lays.
Yeah, it's
Can you go over some of
yeah, they
that?
changed it. I did a lot of it when I was doing sleep, and he's Harvey's changed it to the C3 protocol now,
Okay, so I don't think I know that.
and it involves the NDA,
Yeah.
and they go in. We're gonna do it. We got a guinea pig. Is he here?
No,
he
he left.
bolted.
He changed it.
He ran. Before I forget, I wanted to give you that site for the loops.
Appreciate that,
That is called, oh, you're welcome. It's called Loop Laser Light. And they've got, yeah. So they just call them and tell them what time they have. Yeah, so they got the ones that like different styles.
It was so nice. You're rocking the first guy. I zoom, so you
Yeah, it's got the 3 different settings.
have you tried Argos? I'm like, I think I'm too I think I can handle the coverage. Give people props that they can handle. Oh, you mean? Do you use them? Yeah, we like so bad. Yeah. But I was in all of them 3 years before I came in. I had my ideas about it. And I tried it.
Okay, so night lays is called C3 now. So, this kind of the history of it. Harvey started developing the protocols in 2011. That's why I was down. I was in his office for the first class he did down there. That's how long ago it was. And it was purely an erbium, and I think he was using an R16 handpiece, which was a 7mm spot sight, but it wasn't the little what do they call it? The little pixelated one. Pixelated, yeah. So, but yeah, now he involves pre-treating areas with NDA to warm and to basically liquefy hyaluronic acid and then go in with the erbium. So basically they should be screened. What we used it for when we were doing it was for those patients that were super mild, that definitely didn't want to wear a CPAP or even an appliance. We were able to have good results. It also worked really nice on more severe patients where we had to put them in an appliance, but the appliance only got them so far. And we were able to stack the nightlays on top of it and get a lot of those severe patients down to mild stage. Helped quite a bit. So this nightly C3 consists of a dual wavelength treatment of the floor of the mouth, which there was no floor of the mouth when I went through, the soft palate, uvula, tonsillar fillers, and the tongue, which we didn't treat either. So he's added that. So no anesthetic, no needles needed. Really, warmth is all the patient should feel. It should not sting or burn or anything. And just it's going to consist of, typically minimal is 3 treatments, and the other thing he's kind of changed with it is realization that, hey, some people just need more than 3 treatments. You know, somebody comes in with a high BMI or whatever, they're going to take more than somebody else that doesn't have the anatomical issues going on. So he's gotten immediate results after the first treatment of up to average of 50% reduction in snoring, volume and tone. So, and the photothermal reaction is such that it's kind of interesting. They did some studies that with the NDA with the erbium particularly, even though it's so superficial, they can heat the tissue temperature up to a point that you would consider that you would think it would damage it, but it's so shallow, it dissipates so quickly, the tissue handles it, and that's where the reaction comes from. So what they get is more of new collagen conversion and new growth of collagen fibers. So anything you see with, I know with the nightlays basically carries over to with like some of the aesthetic end of it, smooth lays, lip lays, that kind of stuff. It works the same way. Collagen is collagen. So, and if you can treat it where you rejuvenate the collagen or get new fibers, guess what? Some of it gets better, so it's kind of turns back the clock. So they do a thorough aesthetic course down in Dallas. So that's where they do the big course now. We already talked about chromophore being hemoglobin for NDA, the water, erbium. Basically the pulsing, the newer light walkers. I'm talking about the last. How long have they had smooth mode on them now? 5 years or more?
Yeah,
like 5, 6 years. Yeah. So if you got a light walker within the last 5 years, you've got an extra setting that mine didn't have. It's called the smooth mode, and that's what is specifically used for this and the aesthetic procedures. So why we're using NDA with the warming ability, but we also get neuromuscular effects. I talked about hyaluronic acid liquefaction for improved facial mobility, improved cellular signaling, vagus nerve stimulation, get rid of excess fat cells and activating the fibroblast cells. And just some of the studies that talk about that they've done on it. From a pediatric standpoint, it's used tonsil lays, night lays, PBM. They teach oral lays. It's a big thing. Is it Nordstrom? Mm-hmm. Yeah, Nordstrom. It teaches oral lays. I know there's the mother and daughter team down in Florida. Is that where they are doing a lot of that oral lays?
I think it's Andy Tenholder.
Yes. No, Angie's over in Illinois, right?
I think so.
Yeah, she does that, yeah, she was in my neck of the woods. So just part of the pediatric part, we're talking about oral myofunctional therapy, we're talking about orthodontics, whatever, broadening the palate, mandibular advancement appliances, and night lays is starting to become part of the protocol on pediatric sleep issues as well. So, laser alternatives, a lot of the CO2 guys are now coming up with their own sleep protocol. I read some studies on that. Some of the issues with that is too much heat issues going on, and they're getting some burning and they're getting some scarring, and a lot of times they'll get immediate results, but if they get scarring, all sleep apnea treatment, you're going to eventually falls back or starts to fail. So repeatability is really important. So even people with CPAPs will go years with it and then end up having to keep turning it up, and the body starts to adjust to it. Even with, with your mandibular advancement appliances, you have the patient set, and all of a sudden, whether they gain a few pounds or just over time, their wife complains about them snoring again, or they're having more episodes, you got to advance it even more. The nice thing that I found about the night lays is it does not do any permanent damage to the collagen. It rejuvenates, and then say a few years down the road, if you need to get treatment again, it works again. So when you start getting in and you start scarring this tissue or causing scar tissue to develop, you get one shot at it, and if it starts to fail, you can't treat it again. That's part of the problem.
It's interesting because several of them say that absolutely does not happen.
They don't, doesn't happen?
Yeah, I've been to other lectures, right?
Yeah, I know.
I went to one more for phonectomy stuff, but they talked a little bit about it, and they're like, that does not happen.
Yeah, I talked to a DECA guy, and he was saying that, but there are articles out there that show it, so.
Right.
So, I don't know. So, everybody's gonna tout their stuff. So mild to severe cases of OSA have shown improvement. Daytime improvements also seen with night lays, 24 hours of improved nasal breathing, and less experience as of this stage with upper airway resistance. So this is the handpiece for the erbium end of it all. It's the PSO4, and then the erbium YAG handpiece you can use is the R30. So to do basically pump the energy in there. So this is a pixelated handpiece. When you shine it on the tissue, it's like a waffle iron, I guess, or something. Just a bunch of little pixels versus a solid. So yeah, this is the R30. So I know he's got that up there. So and this little gauge allows you to, it's a measuring that allows you to adjust the spot size, or you could just do it manually like we do our NDA. So this is the protocol we're going to follow. So what we do is initially go in and we're going to treat the tongue, the floor of the mouth, below the tongue with the NDA, follow it up immediately with the erbium, and then we'll do the same thing for the tonsillar fillers, for the soft palate, and for the base of the tongue. Okay, so NDA first, just like back and forth passage with the NDA, right in, and the only thing we don't treat with the NDA is the uvula. So, we don't want collagen formation in the uvula. So it kind of gets in the way. So floor of the mouth is going to get treated with the NDA. Patients feel warming sensation, and then we're going to do the erbium smooth, and then so back of the tongue NDA. And then traditional twin light night lays is what we did was the palate, the tonsillar fillers. So what was added now was the tongue and the floor of the mouth. So we're getting a reduction in the collapsibility of the airway. The neuromuscular control helps keep that airway open. So that's just a heat, showing the heat generated treatment. And this is some of the case results as far as showing improved tongue mobility. guess what, linguophorectomy. So, but the one thing we used to take the pictures of is this. So after we would do a treatment, you know, we did it every treatment, we would take a pre-treatment, and we're looking at the drop of the soft palate, and as we treated, the patient basically opens her mouth, take a picture of the soft palate, and we want to start seeing this uvula lift higher and higher and higher. And that's visually where we're getting good results. So, don't see any of the open airway, back of the throat, and then now, after treatment, so we've got more collagen reaction. So again, shrinkage, it almost looked like the uvula shrank in this case. And again, just soft palate, apron hanging down, and it's able to go higher and higher. Cool.
Have you found that when it's like, I have some patients where if the soft palate is, it extends a little, I guess more anterior, versus like it feels like it starts like right at the base of the tongue and going down. It just, I haven't had as good of luck with that when it's tighter back there as somebody who's got a little more space. Like those patients, so then I'm wondering.
Like the whole soft palate's too far forward?
Initially, right, like, so like if the soft palate is like, almost like, feels like it's starting more towards the base of the tongue in the back, you know, when you're trying to
And it
get
goes
down there,
down
like,
lower?
yeah, like,
part of the
I'm
problem
not
is,
really.
part of the problem is the gagging.
I mean, I
Yeah,
just
those patients are hard because you can't get everything treated as you want to, because you get anywhere, I mean, you know, they're gagging like crazy on you.
Yeah,
So a lot of it is just like, I used to look for, okay, I'm gonna treat this, and hopefully next time I can get like,
right,
you know, half a centimeter further down the chain, and a half a centimeter, and some of them, I never could get, like the full tonsillar pillar, or even down to the uvula area, because I mean, they were gagging so bad.
yeah.
So, I don't think he really promotes it, is, I would use, sometimes I'd use like a chloroseptic spray sometimes, you know, and you don't want the fluid on there or anything, but it would numb it enough to improve the gagging, which allowed me to get down there a little bit, but I don't know if Harvey's really keen on that, but I'm like, hell, there's no other way I could get down there anywhere close to the lower half of the palate, soft palate, you know.
Okay, I just noticed honestly, they definitely have some that's like great, and other ones, like, it's just like nothing, like no change.
So. Are you gonna do it?
Yeah, now that you mentioned the gag reflex, I'm like, okay, it's gonna be interesting.
Now you're gonna gag, huh?
That's my
All right. Go upstairs and you got a guinea pig.
Is that for the 9 days?
Okay.
We'll just meet in the same operatory in
Okay.
5 minutes.
That's fine.
Okay, awesome.
So are you doing that?
Not anymore, but when I did it, we got decent results.
So I don't want to hear, but, one of the doctors in the, you asked for, you saw the disease area, because she says that we were snoring less, like,
We did take-home tests, and we did see difference in her as a child. Yeah. So, and that's, we did Brave on, we used the Brave on.
I was hoping I'd see it. Yeah, and I think Bill for sure. Yeah, and this was, they can, whatever, it treats based on a number, so might as well just treat it.
Is she doing the newest protocol, or is she?
She did, her fitness class about a year ago. Yeah.
Did she send that information on to him? She should contact him. Yeah, she should contact him and throw that his way and see what, you know, see what he says as far as his experience.
interesting shot.
So
Your laser should be fine. You should be fine.
Because we were reading in the board for the hiking, they were saying, like if your laser certified, you can have any brand, you just make sure you have class with the brand.
Yeah.
Like right now,
Class
my
with
class with you,
Who cares?
which is Fotona.
Right.
So that should be
That
fine.
should be fine, yeah.
That's what it says in the board. Just be sure you have the training
I know,
to
right?
use that laser.
Yeah, I mean, really just know the operation of the laser, what it can do, what it
You just gave me the
effects.
name of the.
The website, okay.
Yeah,
Work on
exactly.
that. Rankin.
Rankin.
So here's the one, I use the patient.
It's funny because I just saw.
I know, he needs to do documents.
I ran the numbers.
The dentist that does the evaluation.
I'm just curious if you
You're doing it for my husband.